Yours is in order. Come, Thomas.
Morning all. I'm presenting regarding this patient on behalf of Medicine 4. The title for the presentation is Below My Feet. So this is a short summary of the patient, what the patient came with. This is a 56-year-old gentleman who had 56-year-old gentleman who had come with complaints of fever for 2 days, which is high grade with chills and rigors, with lower abdominal pain and dysuria. Past history, he's a known diabetic for the last 15 years, managed with oral anti-diabetic agents and insulin. In 2021, he had a prostatic abscess also. On examination, he was hemodynamically stable. Per abdominal examination, there was no renal angle tenderness. Per rectal examination was done because he was a male and because of the history of prostatic abscess, and there was some tenderness present. Other systemic examination at presentation, it was thought to be mostly normal. So based on the clinical findings, it is a very straightforward, it's an acute pyelonephritis or a complicated UTI in a 56-year-old gentleman with diabetes mellitus. So our initial investigation showed leukocytosis with the left shift, urine routine showed WBCs. Because we had got the tenderness on prostatic abscess, rectal examination, there was a prostatic abscess, and urine culture had grown E. coli, which is phenotypically consistent with an ESBL. So finally we have come to a diagnosis of a prostatic abscess with diabetes mellitus. So prostatic abscess we've treated with appropriate antibiotic therapy. Initially we had started meropenem. Once the sensitivity had come, we had so that the patient can be followed up on an OPD basis, we had actually planned for oral therapy also, and we had achieved source control also. We had got a drainage of the transrectal drainage of the abscess done. And for diabetes, his HbA1c was 8.8. Insulin doses were optimized and we had discharged. So my question now is there anything further which we should have done for this patient? What further management would you?
It's on Slido.
It's
He's asking open question.
Yeah, it's an open question.
Anybody wants to answer what further management he should have done for the patient? Management or something.
So just a clue. This is a quote from popular culture from the Lord of the Rings movies. Anything? Any answers? Okay. Yes. So that is the thing. So foot examination and evaluation of the complications of diabetes. So our patient did not have any macrovascular complications. Microvascular complications wise, he had decreased sensations below the ankle. And there was a decreased joint position sense. This was his foot. Actually, we asked him history. He actually says around 10 years ago, my foot actually started going down. And then after that, for 8 years, he had, because his foot was pushing out, he had an ulceration also, which took 8 years to heal. So the findings are, you can see some clawing of the digits. Okay, it's not very clear on this picture. There is a loss of the medial longitudinal arch. Actually, in the picture, it's not very clear, but when he's standing, it actually looks like a rocker bottom foot. And he had decreased sensation. The heel scars of previous ulcers we can see, and his dorsalis pedis pulsations were well preserved. So the topic I'd like to look at today is diabetic neuroarthropathy. Does anyone know who this person is?
Charcot.
Yes, this is also known as Charcot's foot. This is Jean-Martin Charcot, a French neurologist who had described the neuroarthropathy in patients with syphilis initially. So in diabetic neuroarthropathy, there are different. Nobody is very clear about what exactly is the pathophysiology behind it, but different theories have been proposed. There is a lack of proprioception and a ligamentous laxity, which causes the foot to be a little more susceptible to minor trauma, which can because this recurrent trauma can cause these problems. Another possibility, like in our patient, is a change in the architecture of the foot, and the weight bearing has changed because he had the deformity. So because of that, he can that can cause that is another possibility. Then autonomic neuropathy can cause AV shunts within the left foot, and even if they have nice bounding pulses, they can still have poor profusion of the nerves and the skin. So because of that, also the progression to a neuroarthropathy is possible. Clinical features acutely they can present with unilateral warmth, redness, edema. Usually, ideally what is described as intact skin with loss of protective sensations. But if there is a concomitant an ulceration at the same time, then that can be also present. So in pain also is present in 30%, even though what is classically described as a inflamed foot with reduced sensations. Then, if there is collapse of the foot ulcers, there can be pressure ulceration, and rarely upper limbs also have been in case reports have been described. So, this is the classification which is seen. The stage 0, 1 is the acute stages, and 2 and 3 are the healing, resolved, and the chronic stages. Evaluation initial is with just blood counts, urea creatinine, ESR, CRP will help. A joint aspiration may be done if you suspect. Our differentials we think of are an infective source and gout. So joint aspiration, if it's a single joint, we can consider gout also. Imaging modalities help in differentiate between infection and Charcot's neuroarthropathy. So for plain X-ray is mainly useful for patients with 2 or 3. If they actually have the deformity, then you can pick up. But otherwise, the sensitivity and specificity is low. Then bone scans, 3-phase bone scan and WBC scans have almost 100% sensitivity and specificity, 90% specificity. So this can help differentiate between active infection versus inflammation. Then MRI also has 99% sensitivity. Its specificity is only 83%. Some things in the MRI which are suggestive of infection are any collections and any presence of any sinuses seen in the MRI. So with regard to X-rays, there are 5 patterns described depending on where in the foot it is affected. And the findings are usually bone resorption in later stages where there is a pencil pointing at the phalanges. Also, there can be sclerosis, subluxation, and dislocation. In this X-ray, what we're seeing is that the tarsometatarsal joints are actually affected here, and there is dislocation present, lateral dislocation present. Some important angles in the X-ray. One is the Meary's angle, which is the angle between the axis of the first metatarsal and angle between the axis of the talus bone. Ideally, this angle should be 0. An angle more than 90 degrees is pathological. Calcaneal pitch is another angle which we look at. It is the angle between the base of the calcaneus and the horizontal surface, and also the angle between the lowest point of the calcaneus to the inclination of the calcaneum. So in our patient, the calcaneal tilt was slightly reduced. It was only 13.3. The other angle was not more than 90. So management requires a multidisciplinary approach. We need there is a requirement of physiotherapy, occupational therapy. There is rehabilitation needs to be involved. Orthopedicians also there is a role. In the acute setting, there is a role for casting to offload the affected foot with total contact casting, and that is only in the early acute stages. In the acute stages, there is no definite role for pharmacotherapy. In 2005, a study has been done, a randomized control trial with 20 patients where there was decreased inflammatory markers and bone turnover markers and decreased pain after 6 months with therapy with oral alendronate. But other than that, there is no definitive evidence for use as regular therapy. Surgical correction is best avoided in most patients because with problems with wound healing and these problems with recurrence also. So learning points are the need for foot examination in a diabetic patient and the things we need to look for to identify a neuropathy. So our patient, what has happened is we had involved PMR also for his care. He has actually bilateral diabetic neuroarthropathy. For his right foot, which we had shown here, he required a rigid arthroplasty, a molded sole for foot prosthesis he got, arthrosis he got, and for the left foot he got footwear with arch support, medial arch support. Thank you. This is Charcot. Other things he was known for was at that point a connection between hysteria and hypnosis. And this is him. Many other contributions in neurology also he has done. This is him painting of him. This is. Thank you.
Thank you, Thomas, for pointing out history also. Also, Charcot married too, and he was the teacher of Babinski also.
Even Torres,
They hated
Torres, all those people have worked with him, and he made sure everyone is named. All these things were named after him. He was the one who started all that.
He was very particular that everything should be named after him. That's very. Any questions from the audience? How long was he having diabetes? Long-standing diabetes.
15 years, poorly controlled diabetes.
And this is the first time somebody has noticed he's got this.
He's gotten treatment for the ulcers, recurrent ulcers outside. He's gone to Malaysia and gotten treated. It took 8 years.
But nobody examined the foot and thought he needed appropriate footwear.
Yes.
Thank you for highlighting the importance of that, Thomas. We'll go on to the next patient. Next case by Gladys, 6 spindles.